Was to be presented by Dr. Shashank, but somehow there is some emergency and he is unable to come, so I am presenting on his behalf. So some of presentation is partly his. So as the time is short, I think I will go fast. So we can skip the. Traditionally, ILM pilling was advocated in presence of VMT or refractory DME, but over the years, we also observed late ERM formation in some types of PDR cases undergone vitrectomy, such as this patient with macular traction. The surgery was done and everything was fine. The traction was completely released, but some years later, the patient came with LHEP, and we can see the thinning. So there is another patient with extensive mid-peripheral neovascular complexes. The patient developed ERM along supratemporal arcade with traction on macula, and surgery was done. The macular traction was relieved, but the NVCs were too difficult to remove and left alone. It has been long, and even after like many years, the patient is doing fine. This is another case with subiloid hemorrhage and large NVD and macular NV. The surgery, all the traction was removed. The result was good. But after 2 years, the patient developed recurrent NV and ERMs. We can see. So we wondered if had ILM peeling was done during the initial surgery, maybe the ERMs could have been prevented. So meanwhile, this case came to us. PDR with DME was injected with Ozudex, but developed vitreous hemorrhage post Ozudex. The patient got panicked, so we decided to go all in. The cataract was removed in the same sitting, and we can see the Ozudex implant. It was difficult to find the plane of dissection of the NVD easily. So we decided to do ILM peeling first, so as to release its traction over macula, as well as to help reduce the DME. But we can see here the membrane is also coming with ILM. So we are able to find the plane of dissection now. So as we can see, along with ILM, the whole thick fibrovascular membrane is getting peeled off, and the NVD is now isolated. It can be trimmed easily now. So now we have found the plane in all the quadrants, and we can see the result is good. So what are the advantages of ILM peeling in eyes with PDR? The PDR eyes, diabetic eyes, have high incidence of vitreocysis, and ILM peeling makes sure that the outer layer of vitreocysis is removed. Moreover, the PDR eyes also have high incidence of ERMs. So ILM peel allows you to create plane for dissection and release traction of difficult to remove neovascular complexes on macula and surrounding retina. Reduces the incidence of post-op ERMs also. But ILM peeling not it's traumatic also, especially in diabetic eyes because it's more adherent. We can see in this patient after ILM peeling, so developed 2 breaks which are more visible with laser now. Also, a study has found some deleterious effects of macular peeling on retinal microcirculation too, especially in eyes with diabetic retinopathy. So what are the ideal cases of ILM peeling in PDR? As per our observation, we have concluded we advocate that all cases with NVD or NVCs within the arcades or near the arcades, and cases with ERMs or VMT, all these cases have high chances of recurrent ERMs. So preferably we should do ILM peeling in these cases. as we can see, there is a large inferotemporal NV. So this fits into our criteria of ILM peel. Video, I think it's hanging. Okay, yeah. So we did peel the ILM in this case. I think I will skip it. Not a very and the results have been good so far. So this is another case with a difficult to remove neovascularization along supratemporal arcade. Also a large NV inferior to disc also. So we simply trimmed these neovascular fronts and peeled the ILM up to the base of these NVCs. So this relieves the traction of NVCs at macula at least, and practically our job is done. We can see the release of traction on macula, and the macula is returning to normal over time. So there are some cases where we are cautious or even avoid peel. One important is end stage PDR, because the retina usually is atrophic and friable and ILM is tightly adhered. Moreover, the fibrosis of NVCs usually doesn't progress too much in such cases. The only thing you may miss is leave a residual hyaloid which may form ERMs later, but that's not that important. And other scenario is where the neovascular front is far away from macula, as in this case. The macula was free of traction, so ILM wasn't peeled, and the patient is doing well for more than 5 years now. So to conclude, ILM peeling is beneficial in selected cases of PDR with traction at or near macula. And a useful tip is to examine macula by OCT in silicon roll filled dyes and peel ILM at the time of SOR if required. So in some cases it can be done later too. Thanks.
Very well, Dr. Ajay. Where not to peel. I think the take-home message is that apart from area, it always benefits the patient of a PDR or DME to do ILM peeling at the time of surgery, either primary surgery or at the time of removal of silicone oil, because apart from decreasing the chance of rebleed if you're doing around the NV, removing it completely, it also decreases the macular edema, which is helpful for the patient. They do better if ILM peeling is done at some point during the course of their surgery, either primary or during the silicone oil removal if it is being planned. So ILM peeling, if it's done, it's always good to be done. Questions?
I just have a point to make. I think we should not underestimate the field effects of ILM peeling, especially in diabetic with large macular edema. Because as it is, the macula is tighting. We try to peel, it is mostly tenacious and we produce damages for nerve fiber there. Not that we don't do that, we definitely do that. But I tend to follow foveal sparing ILM peeling because iatrogenic macular hole in the post-operative period, especially when the edema resolves, there's something which we see commonly. So I tend to do a fovea sparing ILM, whereby the forces are made towards the center of the fovea. And it has been described in the literature also. And another thing I just want to say is ILM peeling is good, especially for disc bleeds. Because as we know, ILM covers the macular area, but as it goes over the disc, it is again a 1/4 thickness of ILM. It's called ILM, inner lifting membrane of the disc. So while you're peeling ILM over the foveal area towards the disc, a thin layer over the disc also goes on. And that prevents, that stops the bleed. Sometimes if there is loose recurrent, that also stops.
Yeah, your point of leaving the fovea sparing ILM peeling is good, but I haven't seen macular hole developing in diabetic PDR cases, especially. But yeah, in high myopes we have seen. I also have 3 cases where Barras laser was done, and in high myopes. And since then, in retinal detachment cases, I have stopped doing ILM peeling at center of fovea. I try to leave it.
Yes.
Sometimes it comes together with that, and I'm not able. But mostly I try to.
Yeah,
stay
it's-
the food.
Large macular edema, 1,000 and above micron. Where
I think when you
those
have
cases-
a
No,
when
in
you have a
those-
cystoid at phobia, I
Yeah,
think
obviously.
definitely
Cystoid
phobia
edema-
sparing. Of
That's-
late, what we have realized is if your macula is visible, we are using OCT angio to decide our peeling technique. And that's very useful. If you see a lot of macular ischemia involving phobia, then I think there is definitely a case of doing a phobia sparing. And sometimes you can pick smaller neovascular tweaks very close to phobia. And then you go back and see your video, you will realize you were encountering more resistance in that area. There was such a small neovascular twig that you were not able to see intraoperatively, but OCT angio could show you that there was that thing. So you have to be more careful. You can create a tear. So I think more we are peeling, we are getting more and more informed that how do we modify our technique. But one thing is definitely I agree with you. Don't force your peeling in these vascular cases. It's not like your macular hole cases where you do a smooth peeling. You have to judge the adhesion. If ILM is more tightly adherent, I think suspect that something is wrong. Spare that area rather than forcing it, because tearing is very easy in avascular retina as compared to healthy retina.
And
If
second
you can
point
see
is actually-
pre-operatively, you can always give steroids and defer surgery for a week or 2 weeks.
Make the
It's only-
let the macular edema come down at the level and then go ahead and yeah, that's a good technique.
And moreover, most of us, I think, peel the disc, and only in the videos because of short time we haven't shown full ILM peeling here. But mostly we.
that I've actually it's very useful because many times after you remove an NVD from the disc, there will be remnant of fibrous tissue there, which is actually the source of recurrent bleed from there. So by peeling that ILM and taking it over the disc, you're actually removing that also, and immediately you see that the
Yes, except sometimes we leave nasal to disc, but otherwise inferior, superior, temporal to disc. Usually we extend the peeling to that area.